So now the arc of that has changed, right? So a lot of these referral patterns that you're talking about have actually been disaggregating over some time, right? So before you had a primary care doctor, and that primary care doctor would then send you to a specialist, and that specialist would then say, hey, we need to do this to you, that to you. And then they have a hospital that they work with, and that's where the procedure would be done. And for the most part, that's still holding. But what's happening now is that, for example, you mentioned Walgreens, and CVS was kind of one of the first movers in the pharmacy space with Minute Clinic in this area. But then Walgreens with Village MD and the recent buyout of Summit demonstrates that they're realizing that, we can become effectively the gate to healthcare for most primary care considerations. They've got Village MD, they've got Summit. They are a pharmacy by definition. They control a lot of the drug spend. They also sell a bunch of other things in the pharmacy. So it works. I would imagine their economic model works really nicely if you can actually take care of patients, get their meds there, and get anything else there that they need. And then, they're also, I think, exploring Medicare Advantage plans over time. And we're seeing this actually grow into the grocery chain. Like Kroger is actually very forward leaning on this, so now you can go to Kroger at some point in the near future and get your primary care visit and your meds and your bananas on the way out.
Welcome to the Message Engineer podcast. We're delighted to have Fahad Rahman here with us today. Fahad has spent more than 15 years as a healthcare innovator working to improve care delivery and outcomes. From the foundation of 2 master's degrees, one in finance and one in neuroscience. And immediately prior to founding his current company, he was a leader in Geisinger Health Systems' healthcare innovation arm, where he helped restructure care delivery for other large health systems. Fahad is currently the co-founder and CEO of Lumi Health, where they work to improve selection, dosage, and titration of complex medication therapy, such as in heart failure patients. Fahad is joining us today from his home in Northern Virginia. Welcome to the Message Engineer podcast.
Thank you so much, and thank you for the kind introduction. I'm super excited to be here today.
Great. So we'll jump into it. I like to start with what I call kind of define the word warm-up. So I will give you a couple of words and ask you in your terms to kind of define them, or what do they mean to you. So the first one should be obvious. Message.
Sentiment.
Sentiment. That was very concise. Okay, second one, value-based care.
Doing things better repeatedly.
And last one, just for you, retailization.
Thinking about the patient.
Got it. Great. Very interesting answers. Message, sentiment. Can you tell me a little bit more about why you said sentiment?
Sure. One of the things that I think about when it comes to messaging is that there's different parts of us that a message hits. But in my experience, that sort of sentiment or feeling or that emotional connection typically drives a lot of engagement. And I think a lot of the data out there, I'm not a message expert like you, but I think a lot of the data shows that there's very interesting parts of the human psyche and being and what we value that's important. And things, we are sentimental creatures. I think is one of the reasons why Happy Meals continue to sell at McDonald's is we think about when we were younger and how we loved the Happy Meal and the toy, and we're customers for life at McDonald's because of that sentiment. So McDonald's is going to sell us on what they have. We already know that it's bad for us, but we still buy it anyways.
That's a great point. And it's definitely true that messages which have an emotional connection are stronger, right? Are stronger and tend to carry the day from that standpoint. So the Happy Meal example is an interesting one. Value-based care. So when you're talking about kind of that being patient-centric or patient-focused, Can you provide a little bit more color to
Yeah,
that?
it's interesting. I came into healthcare from not being a healthcare insider, right? So I used to do management consulting, and as this episode progresses, maybe I'll be able to share a little bit about my story and my family story with healthcare. But we're probably the only industry that has a name for trying to do things better. Other industries just do things better, right? Like, we don't say UPS is like exceptional supply chain optimization, right? I mean, they just deliver stuff, we get the outcome, so on and so forth. So I think in healthcare, we actually have, if we have something called value-based healthcare, we also have something that's non-value-based healthcare, which is basically the status quo, which is kind of insane, right? And so at the core of value-based care is really about repeatability, demonstrability of outcomes, and consistency in some manner that actually drives down costs while improving outcomes and improving experience. And there's so many different imperatives that it has to meet. So it really is about doing things better consistently. There is a patient focus, but a lot of value-based care actually needs to be oriented around providers too. Just throwing a bunch of stuff at doctors and nurses and pharmacists is leading to insane burnout problem, right? So there's multiple stakeholders, but it's really just about doing, in my feeling, doing things better consistently, repeatably, measurably to help everybody over the long term.
That makes a lot of sense. And a lot of medicine, I mean, there's this whole concept, right, of practice of medicine being that ability to modify and choose and make these kind of decisions, which may or may not kind of conform with what we think of as best practice, which are kind of guidelines, right? But guidelines can only follow, societal clinical guidelines can only provide a direction and not kind of an absolute endpoint. And so how do you find that middle ground? How do you drive value-based care to kind of get the best outcomes in such a myriad group of patients when, even though you have these guidelines, right, and best practices, they don't always seep through to physicians, and then there's so much practice of medicine, kind of judgment that happens?
Yeah, it's a great question. And I'll try to be concise because this could take up your entire podcast and probably even more. But I think one of the things that that we have to think about is what's the current architecture of healthcare, right? The current architecture of healthcare is generally, so the preponderance of dollars are in getting paid on utilization, doing things to people, giving things to people, and that gives you money,
Mhm.
right, in the form of codes and reimbursement. Actually, our entire technical architecture is built around that. Electronic medical record systems are not actually electronic medical record systems. They're billing and documentation platforms for reimbursement that, by the way, also have a way to document things for billing and coding, not necessarily for care delivery, right? So the entire system is architected a specific way. When we think about value-based care, the lines of sight are actually really, really challenging because you're talking about maybe preventing something or creating or reducing costs or creating clinical value that by definition may be really, really difficult to measure. What is the cost of preventing somebody's diabetes or delaying the onset of diabetes by 5 or 10 years? There's no mathematical formula for that. There's actually, you can't even build a reimbursement model around that today. So, where we're starting at in value-based care is the reduction of errors part of the equation, right? A lot of that has to do with what you talked about of, we know that there are guidelines, there's non-compliance with guidelines. We can't say the guidelines are the be-all, end-all, but they're sort of the driving manual of the healthcare world, right? They won't tell you how to drive a car
Right.
better, but they at least tell you which side of the road to drive on and what not to do, right? And we're still not following that at scale, right? We have a lot of deviation from guideline. This is one of the things that Lumi does around medication therapy specifically. So how do we get folks to at least drive on the same side of the road and improve consistency on that? But then over time, how do we actually change the way we're delivering care to create a longer arc of how we think about patients and how we think about outcomes? If you've been inside an EMR these days, there's a billion quality measures, right? I mean, physicians and their staffs and hospitals are constantly, like, I call this problem the tyranny of the quality measures, right? There's quality measures that are introduced but never really removed, right? So we started off with maybe dozens of them. Now we have hundreds of them. And if this problem is never curtailed, we may end up with thousands of them, right? And so there's so much documentation, everything that's happening. But at scale, what we're actually finding is that you can be amazing at quality measures, but still not really demonstrably move a population's outcomes in any meaningful way. So there's some more research that needs to be done around specific type of quality measures and what the efficacy of those is. And I think we're still in the learning process right now, and there's going to take a lot of time to figure out. Even the leading health systems in this space are learning and evolving, right? So yeah, that's sort of where we are. I think that this is a big journey for healthcare in this country, and we are seeing different folks doing different things, and hopefully it all kind of comes together in meaningful ways.
Yeah, I think that is a great way to characterize it, right? We're trying to get everyone to drive on the same side of the road, like step one, and that these quality measures, maybe they have a time frame on them. Maybe it's good to kind of elevate for a period of time, but to continue to grow those out to drive care to have so many different quality measures perhaps dilutes the value of the newer ones, and being able to kind of learn from that and incorporate it into practice and move ahead.
Yeah, so
Can't focus on all of them at the same time.
And here's the thing, right? It's like anything in anything you deal with a metric, a quality measure is just a performance metric, right? And so corporate America has already gone through this. I used to work in this space, right? The scorecard, the balanced scorecard, all these different approaches. Healthcare is like at least 10 to 15 years behind, right? So one of the things that we should first do is learn from these other industries. Like, I don't think GE or Procter and Gamble or some of these other, UPS, take your pick of high performing companies that have been around for a long time that do complicated things. Their methodologies out there, right? Why are we only thinking about the methodology from an insider perspective? We should think about KPI metric performances from other industries and extrapolate what we can, because there's a rationalization that's going to need to happen at some time. And in Geisinger, this is what we would do. We would create composite quality measures. So instead of tracking 7 things, you target one thing, and that one thing flows down to these multiple other measures. It helped to down rationalize the number of things that somebody would need to manage. And that's, I think, if you talk to any physician, they're just like, yeah, that we found that to be very, very successful with the folks that I worked at over there that did that type of work, because it reduced down the documentation and tracking imperative, and doctors can then get back to doing what they do best, which is taking care of patients and thinking through deeply clinical problems, on a one-to-one basis to improve outcomes. But there's a push and pull. There's only a limited amount of time and resources. So you can spend that time chasing a quality measure. You can actually spend that time improving care. And sometimes those things are not necessarily as neatly aligned as we'd like to think.
I think there are a couple of interesting points you made in there. One is this idea of simplifying what's complex, right? Taking multiple measures and distilling it into kind of one that then is kind of like the keystone, if you will, that drives the rest. That makes a tremendous amount of sense in kind of approaching these things. And when you look at, hospitals are healthcare systems, let's say broadly, are looking at quality measures, are looking at clinical guidelines, they're managing innovation, they're managing, patients, profit margins, providers, right? More and more, healthcare systems, at least in the United States and IDNs, have been purchasing up kind of additional entities and rolling them up into in this kind of latest iteration the last year or so, to kind of build out this care continuum for patients. And value-based care is happening in certain places, right? Like ACOs. It's happening in certain places where healthcare systems and IDNs are contracting with payers for a piece of their business to accept certain amounts of risk. When you think about it from a startup, right? From like a medtech startup standpoint, what should medtech startups be thinking about when the bulk of the market is still fee for service? How can they kind of not miss the boat on where it's going relative to value-based?
I think that's a spectacular question, because we are in a transitory period, right? So one of the things that we learned, and we have learnings even before launching Lumi from not only from Geisinger, but one of our advisors comes from Ochsner Health System, which is another IDN based in New Orleans, and very similar along the clinic model of Mayo and Intermountain, Kaiser. Very, these entities kind of operate very similarly. And there's some data that shows that for an IDN or a health system to start thinking in value-based care language, right? In terms of how they think about revenue and how they think about outcomes and penalties and savings. All of their money doesn't have to be in value-based care, right? Around 30%, if 30% of their revenue is around in value-based care, and I believe this comes from a McKinsey study, they think of all of their money as coming from the same type of source. So there's a shift that happens at that 30% inflection point. Now that's particularly important because in answering your question, the vast preponderance of dollars still in healthcare broadly are, fee for service or semi fee for service economics, right? Even a lot of what we would call value-based care plans are really fee for service underlying economics with the value-based care type of wrapper on it. And that's okay because different organizations, different geographies are at different levels of maturation. But for startups, what they need to think about is who are they targeting? What are they targeting with? What is their thing, right? Especially, a lot of this applies to services, right? If you're selling pure tech, you're typically on a technology type of economic model. And if you were in a value-based care paradigm, you would be talking about how you improve clinical outcomes or quality improvement or cost reduction, right? But on the service side, it gets a little tricky because then you have to really think about, okay, and we're a tech-enabled service company. We do polypharmacy management. We sit, we're building in the current, environment, but we're planning for the future. So what I say is we're living in reality, but we're planning for what's coming next. And so that means being transitory yourself, working within, if you're, the guidance I would have is if your core customers are mostly driving their money from fee for service, then you may want to align with that. Because if you bring in an economic model that they're not fully baked into, or they don't see as being their dominant economic model, then you're going to have a lot more difficult time selling to them because you're going to have to create a value creation mechanism that's going to justify the type of things that you would want to have. The other thing that comes in is value-based care has to do with shared risk, right? Fee for service is purely transactional. So, if you were to create a value-based care platform, technology, tech-enabled services, devices, meds, all these things are going to get wrapped into value-based care. You have to think about what that financial architecture looks like. We're not very mature in that space. Like we do, we as a healthcare system, we do work in heart failure. I have not come across a very good heart failure value-based care model. The single biggest thing that people typically focus on is reduction of heart failure readmissions for Medicare patients because they're so abysmally high and costly. But that's not a really, for us to say that we did fewer errors is not a really good way that we're, by definition, also providing value, right? So what I would say is that startups need to think deeply about their customer base, the economics of those customers, and that likely they will be, especially if they're targeting health systems, but also many of the plans, they are underlying fee-for-service economics. Where we're seeing a lot more, I think, acceleration is when you see employers, funded plans where they're taking risk on the population by definition. They have a lot more autonomy in terms of who they can contract with. That typically becomes an entry point, but growing and scaling in there has been demonstrably challenging for many startups. But then what you see happening with this advent of payviders, Humana going deeper into the delivery ecosystem, Optum, both has a payer side at UHC, but now owning ASCs and owning clinics outright and thousands of doctors. There they own the value chain. So it's going to be a lot easier to sell to them and say, hey, we can deliver the same outcomes or better outcomes at a lower unit economic price or lower utilization. You'll get their attention. So I think that we're at that point now, and we were definitely not at that point maybe 4 or 5 years ago. So there is progress.
Great. And I think one of the things that I want to kind of jump to from that is kind of even perhaps further back when patients are first interacting, right? It used to be very straightforward. You knew who you were going to, they went to their primary care physician, right? And they talked to their, let's say 10 plus years ago, talked to their primary care physician who then referred them to a specialist who may have referred them to another specialist who then, they then get some diagnostics performed. Then perhaps there are additional diagnostics, a therapy at some point, medication, and kind of, bring the circle back around again. And these days, that front end is really shifting and kind of how patients come in and start to interact. And I'm wondering if you could expand a little bit on where we started a bit in the beginning, is this idea idea of, I've heard it called consumerization of healthcare, or retailization of healthcare, or this idea that Walmart and CVS and Amazon and others are attempting to are getting into kind of healthcare and primary care in particular. I mean, as a kind of a medtech startup, and we're thinking about, services, let's say, how does that shift how we need to be thinking about things? Should you still be focusing on kind of the hospital systems? We're trying to build out this continuum of care. Should we be focusing on kind of these retail outlets kind of coming into primary care? I mean, how do you help us think about that, and how kind of startups in particular need to be sorting this changing
No,
ecosystem?
I think it's a spectacular question. So I'll kind of take the timeline a little further back. So in the 90s, a big shift happened in healthcare in the mid to late 90s. Pharmaceutical companies were able to advertise directly to patients on television. You may remember this, right? And that changed the way a patient was actually interacting with their doctor. Before, they'd go to their doctor and they'd be like, "Doctor, I'm feeling like this." The doctor would be like, "Oh, well, I think this is happening, and I give you some meds." Now patients were using WebMD, listening to these ads, going to their doctor with a preliminary diagnosis and saying, "Doctor, I have this and I think I want this med," right? And that trend has continued on today to where and it's not only in healthcare. I mean, we used to go to car lots and we'd be like, "Oh, I like that car, let me buy it." Now we just do all of our research and everything. I mean, Carvana will just deliver a card to you at home, right? And you don't even ever have to interact with the person. So there is a consumerization of the society that's happened over the last couple of decades in ways where the consumer has more information and is proactively going to the subject matter experts in the space, and specifically in healthcare, and kind of coming in with their preliminary findings and then asking them for, "Do you concur with my initial diagnosis or conclusion?" Right? And there are doctors out there that are like, sometimes patients just want a specific medication, and I just give it to them because they ask it so many times and they've sort of become adamant about it, all things being considered, if it's appropriate. So now the arc of that has changed, right? So a lot of these referral patterns that you're talking about have actually been disaggregating over some time, right? So before, you had a primary care doctor, and that primary care doctor would then send you to a specialist, and that specialist would then say, "Hey, we need to do this to you, that to you." And then they have a hospital that they work with, and that's where the procedure would be done. And for the most part, that's still holding. But what's happening now is that, for example, you mentioned Walgreens, and CVS was kind of one of the first movers in the pharmacy space with Minute Clinic in this area. But then Walgreens with Village MD and the recent buyout of Summit demonstrates that they're realizing that, oh, we can become effectively the gate to healthcare for most primary care considerations. They've got Village MD, they've got Summit. They are a pharmacy by definition. They control a lot of the drug spend. They also sell a bunch of other things in the pharmacy. So it works. I would imagine their economic model works really nicely if you can actually take care of patients, get their meds there, and get anything else there that they need. And then, they're also, I think, exploring Medicare Advantage plans over time. And we're seeing this actually grow into the grocery chain. Like Kroger is actually very forward leaning on this. So now you can go to Kroger at some point in the near future and get your primary care visit and your meds and your bananas on the way out, right? And you don't have to go anywhere else. So it makes sense from a retail perspective of retail revenue capture. It also makes sense from a perspective of opening more access points into the healthcare system. Now, to your question, well, what does this mean for hospitals, right? What do the referral patterns look like? Does your local Walgreens connect in with your local health system? And do they have specialty groups? And so that's why they bought Summit out, likely. And that's why you'll see probably something happening with some of these other players is, they have to link up with the referral entities to then think about how to manage at least the outpatient side of the care continuum. So I'm sure, this is going to continue on as we look at telehealth. It's a modality, right? So people became really accustomed to getting care at home, getting care remotely without having to go into brick and mortar. And we're in that space of virtual care and remote patient monitoring and polypharmacy for older patients in the home. So, do you want, grandma getting in a car, going to a local, Walgreens or Walmart or, physician practice? Or do you want more and more of that care delivered directly to grandma in her living room, in her bedroom, in a virtual, way? And we're seeing a lot of stuff happening in home health too, where home health assets are being bought. So I think the locus of care is shifting outside and closer to the home. and also closer to these consumer retail areas where we typically are trafficking anyways. We're going to pick up our meds, we're going to pick up our groceries. Why not just get a prime? The bank's already figured this out. They just built the bank and the Starbucks inside the grocery store. Healthcare is just, I think, following the same trend, frankly.
That's a great point about the banks figuring that out a long time ago in Starbucks, because yeah, I see those everywhere.
Sometimes you'll see a Starbucks inside the grocery store and then next to the grocery store too, right? Like independently. So
oh, that's funny. I think that it is certainly becoming really interesting to kind of watch, see, and attempt to predict a little bit what's happening here and what people are going to need: patients, providers, retailers, right? Practitioners or healthcare practitioners, providers, and how we kind of tease all of that out. Do you see any? So, for example, it used to be when you have services in particular, like an EMR and EHR, those types of things, that you would want to be able to sell them into kind of hospitals or a hospital that was part of a broader group of hospitals, right? As a system or an IDN, so that you can kind of pilot it at one and then kind of maybe spread it across the other ones. What do you think is the right approach to this kind of shifting, transitional kind of, retailization of healthcare and service, the services crossing the services that are needed a lot of times that are innovative to hospitals and hospital systems? They think about things very differently than like a Walmart or a CVS or a, Walgreens, and those sort of folks do.
yeah, I mean, I think what we can pretty much surmise, at least this is what our experience is, and we've done a lot of work in EMR redesign. So if somebody gets an EMR, it's never the way they expect it to be out of the package, and they got to spend years and a lot of money and continue. It's like becomes the thing that's always being worked on, but the work is never complete, right? And that's sort of the nature. If you know anybody that has any of the EMR platforms, especially the larger ones, this is like what they'll say, right? They have armies of people that are constantly updating and managing it, and it's core to business, so that should be expected. It's the same in the corporate world with databases and CRMs and so on and so forth. So, but
Right.
fundamentally, there's a couple of things that are happening. One is the experience is going to get more fragmented, right? So when we think about who the ultimate consumer is in healthcare, the ultimate consumer is the patient. So we actually have a real big problem in healthcare where patient satisfaction is really low. Patients are typically indexed with disproportionate amount of responsibility for managing their own care and managing data information and regurgitating the same stuff that people should know over and over again every time you fill out a form and so on and so forth. Once again, not very complicated technologically to do any of this stuff. I just don't know like why, I know why there's structural impediments to it, but when you in other industries and other experiences, we would never accept that. We would never accept that from Amazon. We would never accept that from Netflix. We just don't, but somehow we do in healthcare. So I think there are layers that need to be created that go above and beyond the EMR that integrate with it to deliver care, right, effectively. Take data from the EMR, take knowledge, you layer on top of it, and it's fine. It's great to create value care layers on top of it. It's one of the things that we're doing. We're saying, hey, medications are highly specialized products with very specific physiological and symptomological reactions. We should be very, determined in how we actually dose and titrate and adjust medications, and we should look at the physiological, feedback from patients and how they're feeling, and figure out whether we should back off something or maybe prescribe something different or change the dosage. None of that's actually able to happen inside an EMR today, but it can happen in conjunction with an EMR. We take data from EMRs, we populate back our recommendations. So I think that there's a whole crop of new companies that are being created and will be created in that space. When I look at what's happening with some of these entities, Walmart is buying Epic, right? So they're going down the, hey, we're not going to build our EMR, we're just going to buy it. Village MD, from what I understand, and I could be wrong on this, I think they built something in-house over time, and that actually becomes part of the Walgreens play as well. So the question really becomes is what assets are being used and created and what layers can be created on it. But ultimately, when you look at disaggregation, the question foundationally, I think what you're asking is, how does the care get integrated now once you've gone to a Walgreens, how are they thinking about you as a patient? Are you still a patient, or were you just a retail customer when you walked in the store? Those are two very different things. Hospitals and health systems tend to think of you as somebody that they have for life effectively, right? Like you go there, they have your data, and you're going to come back there in some way, shape, or form if you need it. How does Walgreens, how does Walmart think about that? Do they have partners in that space? Do they have health system partners? I think at some point they're going to have to link up if they already haven't announced these things. And that goes for, and I don't think any provider can exist independent of the ecosystem in the long run, right? And then when you think about the value-based care paradigm, then effectively you have to sing together, right, in order to, make money and improve outcomes and manage the continuum. And you mentioned ACOs at the beginning of this call, and ACOs have had Medicare ACOs have struggled with that, right? Because the responsibility has been indexed in the primary care group, but the spend has been, going into the hospitals, specialty groups, and they have no control over that. I think some of the new stuff that they've introduced has actually helped to address that problem. But for the better part of like the last 8 or 9 years, Medicare ACOs have generally not been uh, performing as well as they were expected to perform, especially on a shared savings basis. And a lot of that is because who's managing what and who's responsible for what. And I think that game will continue on for a little while until we kind of figure this out.
I think that's, a lot of really brilliant insights in what you said. And I think a lot of it kind of hovers around the idea that in the United States, we're still valuing, or the money flows towards procedures and therapy and not towards health, as in prevention, doing the right thing, getting out in front of it, predictive measures that tell us, hey, if they're going down this path, then they're probably going to run into type 2 diabetes. Let's get them off that path and head them down, some other street, so to speak. So a lot of paradigm shifting going on in that space, and it makes a lot of fun for startups, right? Like yourself, to kind of plug in and figure out where the best fit is, and how and where it is today, and on kind of an ongoing forwards basis, right?
Yeah, I think it isn't, and I think we have to be cognizant. One of the things that we think about a lot, because this is what we see in various different studies and data, is there's multiple components to somebody's overall health outcomes, right? The delivery of healthcare is only around 20 to 25% of it. There's genetic component, there's socioeconomic. If you're meeting a patient for the first time in their 20s, there's a whole host of things that they've already experienced in terms of nutrition and family structure and crime and other risks and so on and so forth, education, that will put them on a specific trajectory. We just know that this is so. And then there's genetic factors that play in. So I think one of the things that we have to think about is what is doable, and how to do that more effectively, and how to go earlier and earlier into the cycle if we're really thinking about prevention and we're thinking about mitigation. And I know there's many Medicaid programs that think deeply about this. We did some work some years ago when I was in a previous role with New York State Medicaid, that launched one of the most ambitious programs in this space as part of their reform program called DISRIP. And they really did think about early childhood nutrition and education and so many other things, community-based organizations. And so I saw that at kind of up close, and realized, wow, there's so much infrastructure and connective tissue that we don't even have in certain parts of this country. And now we're talking a lot about health equity, which is kind of the same. It's an extension of the same type of concept of like, how do you actually deliver and get people the similar or same access to then ultimately improve health outcomes more consistently across different cohorts and populations. So I think we have to think about there's layers of other components that don't exist in the hospital system or don't exist in a clinical office that actually have a seat at the table here, and maybe way earlier in the life cycle of a patient than an interaction with the practitioner of healthcare.
Yeah, and how do we get that line of sight to those things in a way that's appropriate, right? Privacy and all of that, ethics.
And who pays for it, right?
Considered.
Like, is is it a state function, or is it a hospital function, or is it a payer function? We see a lot of work in like we did something at Geisinger called Fresh Food Pharmacy, right, which was in Scranton, Wilkes-Barre area, and they really were prescribing like, nutritious food and then giving it to patients, right, who didn't have that type of access. And we see some payers doing that right now and so on and so forth. But and there's talk about like, oh, affordable housing. So is that a state function or is that a payer? Like, who ultimately is paying for these things? There's going to be at some point some level of delineation, right? I mean, is a insurance company going to start building affordable housing for people in their geography? Maybe, maybe not. I mean, or is that more of a county and state responsibility in conjunction with the payers that operate in that area? I think that things are going to get pretty interesting in the coming years about how to demarcate some of those responsibilities.
Yeah, those are great questions, like big, thorny questions that have yet to be answered in any really kind of like thoughtful, enduring way. And in listening to you, I think about things like ACEs, like adverse childhood experience, right? And you were saying, without saying specifically, social determinants of health, right? All those things that we know go into putting, as you said, people on a specific trajectory from a health standpoint. And where does that intersection take place? Where does that make sense? Yeah. Social, healthcare, how does that come together? People have some pretty strong feelings about that.
Oh yeah. I mean, one of the things that my research may be a little outdated on this, but one of the things that Medicaid in certain states covers is dental, right? So people will go for Medicaid for very specific things. There's obviously in the adult Medicaid population, there's a lot of churn because of eligibility and re-enrollment every year. So, you may have people that churn in and out, but dental coverage is a very, in some states, not every state, it's covered in Medicaid or partially covered. So if somebody's dental health is poor earlier on in life, they will likely develop chronic conditions earlier than the average person in the population. So, they may go in for these dental procedures and they may have deteriorating teeth for various reasons, nutritional reasons, poor hygiene, diabetes, whatever other chronic conditions. But then how are we using that knowledge to actually then, understand and take care of that patient earlier because we're seeing signs of it, right? There's parts of dental hygiene that actually drive certain types of cardiac valvular disease too. There's certain bacterial endocarditis. So I believe is the term for that. So these are all very interesting things. They're known. So we're not talking about the unknown at this point. The question is, how do you create a model that actually effectively gets that knowledge and then intervenes and mitigates and addresses it in a meaningful way? I think that's the $1 million question, right? The care continuum right now is, depending on where you are and which populations you're in, is not continuous for the most part. It's highly experiential, and it's very different from place to place and organization to organization.
Yeah, absolutely. There's no doubt about that. And yeah, how do you connect up dental? That's a great question. I'll just toss in that I had an experience where I thought I broke my toe, first broken bone in my body ever, which is good. And I went to urgent care, right? That would make sense. Hackensack Meridian urgent care.
Great
it's like
health
a mile
system,
from my
right?
home. Right? Great health system. It's directly across the street from the hospital, right? And like great children's hospital, great hospital. And I went in and they said, well, we're pretty sure you have this. We can't say definitively because our x-ray tech is out. I was like, well, can't someone else take the x-ray? No, but they'll be back tomorrow if you want to come back tomorrow. You should really just go to the ER. And I was like, I can walk. Like, I'm not going across the street to an ER because I think I broke my toe. When are they here tomorrow? Right? And so then I have to go back and it gets better. I said, I'm curious. I said, I had to fill out a paper form when I came in. I said, one of the reasons why I keep coming back to Hackensack Meridian is because I want it all in one place. I want everyone to be able to see everything. And I said, so why are you still using paper forms? And they said, oh, you know what? We're on the list to get linked up as part of, right, the EMR and the EHR initiative. But we're not there yet. They cited some double-digit number on the list. So even though they're literally across the street, it's not connected in any way, shape, or form. And we still have these kind of misses in really simple ways. Yeah, and it was a Saturday. It's not as if it were, an
So
unbusy
how did
day.
that make you feel? I mean, that just sounds.
I generally love Hackensack Meridian. My mom had some issues with TIA. She has AFib. And when she lived with us for a couple of years, and they did they did great with her. I mean, they have a tremendous stroke care center. But my interaction in that particular instance was, it was a bit head scratching, because I'm supposed to be with like the premier, right, hospital system in the state of New Jersey, and I'm not in some far off rural area, right, which is typically, where you say, oh, well, perhaps they're not connected yet, perhaps they're not part of it yet. And we're directly across the street, and it's 2022. And how do you not have an X-ray tech or have like a backup you can call? Or why am I still filling out a paper form? Why don't you at least digitize that piece of it before, right? So that you have the data to then push into the EMR, EHR when you have it. Or why don't you have some default way to do some kind of like download, upload once a month, right? There are known ways to make this work. So yeah, how did it make me feel? Not the greatest about that particular facility. So I still like Hackensack Meridian a lot, but that particular facility, I had to say, why am I even getting in my car? So then I'd done telehealth before, so then I just did telehealth the next time.
Yeah, and
I felt I had better care. I was like, what was the point of me getting in my car?
Your experience is typical, right? And like I would venture to say that there are some rural or non-urban health systems like Geisinger, like Intermountain, which is like in the Rockies, right? For the most part,
Right.
between Colorado and Utah, or Mayo, which is not in Minneapolis, but in Rochester, Minnesota. And so you kind of walk in, I think our null assumption or hypothesis is, heavily populated area, sophisticated health system, well branded at least, they would have this all figured out. But like, we are still dealing with first order problems like paper in healthcare. The amount of time, if we aggregated how much time patients spend regurgitating the same information over and over again, and then waiting for care, and then finding that care is not accessible at that time, or so on and so forth. Once again, it's probably bundles up to like a bunch of hours every year. I'm sure it's probably on the order of like cumulatively months or years of collective patient time, right? And but you can't really go further than that. If these first order things are not solved, there's really there's no room for, like, for example, we find, and the data shows us, that 30 to 50% of the medications in an electronic medical, that a patient is on, are not in an EMR of, for example, the health system that they may go to regularly. Why? Because they may go to another doctor for some other meds, or they may have gone out of state and that doctor prescribed them something and they're taking that medication, but they never told the doctor they go to regularly, like their primary care doctor or one of their specialists. So there's so much, even once you get to the digital side of it, it's so incomplete, right? Experientially, informationally. And then the other thing that you hit on is like, probably you experience a little bit of like the massive labor supply problem we're having in healthcare, right? I mean, it's happening across clinicians. It may have been like I would imagine they would want an X-ray tech there on a Saturday, right? It's probably a higher throughput day, but they may not be able to find one, and because of supply issues, right? And you were seeing this definitely with physicians and nurses, and people talk about burnout and burnout and burnout, and I'm just like, yeah, burnout is a manifestation of operational and structural problems in the system. And it's one of the biggest reasons that when these health systems over the last year, who have, resoundingly, I think, as an industry, been putting up pretty bad, like negative profitability numbers. And they, one of the single biggest things for them is attrition and high labor costs, especially on the clinical side. So, we've got a system where the practitioners in that system there are not enough of them, and the ones that are there are feeling like there's a undue burden on them, and that's not really great when we
Mhm.
think about an aging population, a growing population with growing and growing chronic disease needs, more consumerization. So we have a supply demand inversion that's actually happening, where there's going to be way more demand than supply to deliver it. So we really need to think deeply about how we can scale the people we have today more effectively to take care of larger population sizes more effectively, and that's one of the things that we think a lot about, is how do we actually have pharmacists and nurses on our team, give them superpowers to take care of way larger patient attributions than the ones that we have today, or the ones that are industry standard. Because 5-10 years from now, I think we're not going to be creating enough doctors and nurses and pharmacists and x-ray techs and so on to meet the demand that's coming down the pike. I mean, I think the demand is definitely going up for healthcare needs. The spend is definitely going up astronomically. So yeah, sorry to hear that your experience was like that, but that's pretty typical, unfortunately. And yeah, that's what can we say? We're still using fax, right, to a certain degree in healthcare. So.
Even 20 years ago, I had reps say, I said, our goal for this entire year for the marketing department is to gather physician names and email addresses. So we want to be able to have ongoing communications with them. And I can't tell you how many of them will say, oh, they don't have an email. And I was like, look, I know it's 2005, but they have an email. I know they have an email. They just don't maybe want to give it to us. Fine. Can we have their admin's email? Can we have somebody who's in their, somebody has an email for us to communicate with them? But they're like, well, they have a fax number. That I'm like, no, we're not. I'm not building a database of fax numbers. It's not. I understand that still happens. That is not how we're going to be doing business. So nowadays, of course, it's a foregone conclusion that people provide their email address when they want to be in contact with certain individuals or certain companies. But it wasn't at that point in time. So it was a bit hard won. So I love this idea that you talked about giving pharmacists and nurses kind of superpowers, right? And about the supply, the labor supply, right? Because we already see that in a lot of physician specialties where they're not filling all the slots, right? Residency slots or fellowship slots, depending on the specialty. And so I think that idea of using, folks who like pharmacists and nurses, for example, not to push them to do more, but to make it easier for them to, as you said, give them superpowers.
Yeah, we think
real...
about it in two ways, right? One is something that's kind of ingrained in us, in our DNA. I think, as both my co-founder and I, Yvonne, who also work with me at Geisinger, and then what we're building here at Lumi, is this idea of top of license care, right? So what we have today is a lot of folks that are working below where their license allows them to work. Like an example would be a physician actually trying to schedule an appointment for a patient. Like that doesn't, somebody administrative could do that, right? You wouldn't need a doctor to do that sort of thing. So that's they're working below their license, right? In the clinical
Right.
segmentation, there's a lot of stuff that doctors are doing that nurses could do. There's a lot of things that nurses are doing that a medical assistant could do. So where we come in is that, first of all, we need to figure out how to segment this type of work appropriately and then delegate it, right? When you're talking about one person doing 5 things, it's a lot easier because there's one person managing all 5. We're talking about 4 people doing 5 things, then it becomes a little trickier. Who's doing what? How does the sequencing work? How's the handoffs? So that's what's called care coordination effectively, right? Is the idea of coordinating and collaborating. And this is one of the biggest things that came out from this move after the Affordable Care Act, is the orchestration of care that allows this type of segmentation and delegation. So that's been very interesting. But one of the things that we found is that for medication therapy, we were still indexing very heavily on physicians, but physicians didn't have informational resources, like what's happening with the patient at the home, or what are all the meds they're on, or what's happening to their other organ systems. Like somebody with heart failure also has high blood pressure, diabetes, likely chronic kidney disease, likely chronic obstructive pulmonary disease. So, cardiologists don't have the time, bandwidth, resources, or any other specialist to convene with a nephrologist and a pulmonologist and a primary care doc in some virtual meeting and talk about one patient's complex medication therapy. That just never happens, right? It would be amazing if we could do that, but it's not realistic. So what we thought is, okay, who does know really a lot about medications and knows about guidelines and how to dose and titrate and what the latest research is? Oh, well, we have these people called pharmacists who are by definition experts in medications. They do this all day long, right? And so there's a type of pharmacist called a clinical ambulatory pharmacist that actually works. So this is not the person dispensing your pills at your local pharmacy. They're actually somebody that thinks about sits in a care model and actually does clinical delivery of care. So they can look at the therapy, they can look at the medications, they can look at where there may be improvements or compliance with guideline protocols that you mentioned earlier, but they can also look across the cross comorbidity. So if we change this one med, what might it do to this other med, or this symptom that this patient is expressing? How does that factor in to really following this part of the titration schedule or something like that? So what we're doing is we're actually we work in conjunction with physicians. The pharmacist becomes a part of the physician team effectively and helps to then collaborate on where the medication improvement opportunities might be with patients. And it allows the physician to then react way faster, right? Because now they've had all this, they're not chasing the patient down and calling them in off hours. And, oh, the patient called, there's like phone tag going on, then there's pieces of information missing in the EMR. The pharmacist has done all that work and actually come to the table with some recommendations or opinions, driven both by the technology and the devices that we have, but also by the pharmacist's own knowledge. And then they can work with the cardiologist or any physician and then accelerate the decisioning. And that's what we're really trying to do on a first order basis. On a second order basis is, how do we actually take this knowledge that we have and these recommendations and then build better recommendation models on top of that, right? The analogy would be, in the 90s and the early 2000s, we digitized an analog experience. We took AAA maps and Rand McNally and we made it MapQuest, right? And MapQuest, all it does was you just put a starting and ending place and you print it out and you really have an analog experience again, right? You got these papers that you're running around with and you're looking at on your passenger seat. And then Waze came, right? Google Maps, Waze, and now there's no paper. And we have a reliance on them, not because we may not know the geography of where we live, but there are pieces of information in there that we just don't have knowledge of: traffic, roadblocks, new roads, avoidance of tolls, so many things, right? So it becomes a companion. So what we're actually building is that companion model, because guess what? We can all avoid traffic and we can all avoid the roadblocks. It alleviates congestion on the road dynamically, right? And it makes for a better driving experience for everyone. So that's what we're really trying to build. And we think that both types of artificial intelligence like machine learning and operational and clinical efficacy will help us allow to scale more better over time, and then require less human input and more guidance. And then the humans can really, when you think about it, if you don't have to listen to the radio and flip to the radio stations to hear traffic anymore. The app's telling you if there's traffic. It's already rerouting you, right? And you can focus more on the driving and just having a better experience and avoiding other things along the way that might be harmful. So that's really how we think about scale and efficiency and driving is the best analogy that I can give, because I think it's relatable to so many folks.
Yeah, the driving analogy is a great one. So when you talk about roadblocks and stoppages and unexpected things, right? Because those could be cautions or warnings, or this deviates from, or right. There are different ways to think about that, but that makes a lot of sense. And being able to digitize it and also kind of put the right person on the job. So I don't know what the most recent stat was, but I know it was like 50% of people with, this was hypertension, not heart failure, but it was like 50% of people with high blood pressure, hypertension, who are diagnosed and managed medically, meaning taking some kind of drugs or pills, missed their systolic blood pressure target. How can that even be the case? So I think where you're going and where Lumi is headed is so critically important. Obviously, not just for kind of where you start, but kind of broadly in so many different kind of arenas. to try to reduce the, not acuity, what's the right word? To put the right person on the job so that they're operating, as you said, kind of at the top of their license or top of their responsibility. And allow other people then, by doing that, to do that with theirs. And that should ideally over time also help with things like, besides patient outcomes, burnout, less burnout, et cetera, right? They're doing the things that are enjoyable, that allow them to kind of stretch, and not doing these kind of routine things that other people can handle.
Absolutely. And here's another thing, right? Physicians and clinicians today, when you go in, you get a surgery done, it's an episode, right? You go in, get a surgery done, you're there for a certain amount of time, they discharge you. And that's the hospital acute facilities are built a certain way. And we actually have really, really great acute facilities in this country, right? So any type of surgery you want to get, we're typically at the tops for that, right? What happens, but the care continuum is really short there, right? And the episode is really short. When you've left the hospital, you've now entered life, right? So what's the episode on life? The episode on life is like, it's pretty big, right? So now you're talking about when a physician, a primary care doctor, is optimizing antihypertensive medications. There's a lot of trial and error that happens in that. How many pills, diuretic, sequencing, morning, after, morning, evening, and so on and so forth. There's a lot of adjustment that happens. So a lot of it is like, oh, here are these pills and here's a blood pressure monitor. Tell me, just document your blood pressure. And then like maybe after 3 months or 6 months, we'll see you, and then call us if things get bad. I mean, that's a pretty bad paradigm, right? Like that's just, if we're trying to titrate something that you have upper and lower bounds to manage in, almost like a speed limit, right? Then it would be really good to be monitoring that all the time to see if you're drifting towards a higher speed or going below the minimum speed, right? But no, we don't have that, right? So that's one of the things that we're trying to do at Lumi is say, on the blood pressure side is, what if you had a model where there was actual continuous management, right? And there's a number of other remote patient monitoring companies that are doing this. But the thing that I think we're trying to bring is like, how do you take that information around blood pressure specifically, because almost every heart failure patient also has comorbid high blood pressure, and then build that into a decisioning model to see if there's drift going on, right? Or if there's a sudden change in blood pressure because maybe they had a high salt intake, or maybe it was a adverse drug reaction. So the doctors having that knowledge gives them a whole new level of visibility. They may not react to it, but actually having that information and knowing that somebody's monitoring their patients gives them a ton of peace of mind. Sometimes burnout happens just from not knowing, uncertainty factor, right? What's happening with that patient? What's happening with this patient? What's that? A typical primary care doctor may have 1,500 patients, right? Sometimes 2,000 patients. They're thinking about all of them all the time. And so if you can create a level of understanding of the population of what's happening, and they can feel comfortable that those patients are being monitored and watched, and somebody's working with them, or some technology is looking at what's going on, and they have access to that information, but they don't have to always react to it. That's a win-win for everybody. And I think that that's really, when we think about what's happening with hospital at home and some of the really interesting virtual care models that exist out there, I think this is like the future of healthcare, which is that it's going to create greater awareness, but not necessarily automatic reactivity. Right now, we have a super reactive healthcare system. Somebody says, a problem identified is typically later than it should have been identified, and then we're looking to mitigate and address it and hammer it back into place. And then the next one pops up. It's almost like a game of Whac-A-Mole, the way we are today.
I laugh because I use the Whac-A-Mole analogy for certain things. So I track with that analogy 100%. So I think we've covered a lot today, kind of retailization, value-based care, ACOs, care continuum, a whole host of things that make this entire like ecosystem it's so much more, in my mind, kind of challenging and really interesting, right? At the same time, when you think about being a startup on the outside, and how can you help? How can you influence? How, where should you punch in? Kind of, and why and with whom? And so it's a fascinating time of change, and transition was a word you used. as well. So a lot going on with that, and we could certainly talk about this for a whole lot longer than we kind of have today. So I just have a couple kind of final questions. I saw on your profiles that you love, I don't know how you state, I don't remember how you stated it exactly, but something effective. You love hamburgers, or you're a hamburger connoisseur. So for going to, when I go to like DC, Northern Virginia, I think of Five Guys. Just they're everywhere, but they kind of came from there. Where should we be going instead?
You know what? It's
If we,
I go to Five Guys. That's the place. Maybe not for everyone, but I found that it's just it's a great experience. They've got a great product. They do it right. They figured it out. So yeah, that's my go-to. There's another one here locally called Big Buns. I love the name. and they do a really good burger too. But yeah, those would be the places to try out locally.
Awesome. That's funny. I mentioned Five Guys thinking that you would never say that. So I think of like Dulles, Five Guys.
Yeah, you know the story, right? So that they started off as like a local place here, and then they grew, and now they're international, and it's amazing. I mean, like they really consistently kept the product the same for the most part. The prices obviously change, and we can just attribute that to inflation. But you can go anywhere, and the Five Guys experience will be pretty consistent. But it's not mechanized, so there is some they've threaded the needle nicely, I think.
Yeah, absolutely. Keeping some of the things like slicing their own potatoes.
No freezers,
right? Some of those things that make the product, I think, a much better product to consume. So, in my personal opinion, and my son's for that matter. So, from that standpoint. And if you mentioned, I also saw that you love to travel. So if you could give us one place that we should go to that's not kind of on the, let's say it's off the beaten track, not kind of on the typical tourist path of travel, where might that be, and why should we check it out?
So my family's originally from Pakistan, which is in South Asia, and I think that a lot of the news that we hear about Pakistan is generally not spectacular in the United States. Usually something bad has happened, or something bad is going to happen, or something like that. But it's an amazing country, and I think that if somebody were to be a little adventurous and try it, they would be surprised. I think one of the things that I learned as I travel is that we're all very similar regardless. I've been in countries where I don't know the language, and I'm like out off the beaten path, and people are just humans. Humans are just humans, and we all, I think, generally aspire to many of the similar things that, security, food, shelter, camaraderie, avoidance of conflict. Like those are just, I think, some pretty normal values. And so I think one of the things that I would say about Pakistan is that I have not even traveled extensively around the country, but it has a lot to offer. I've traveled there many, many times, and you'd be surprised at how diverse the country is. There's multiple countries in one country. You've got everything from like beaches and deserts to the highest mountains on earth. You've got actually descendants from Alexander the Great still living in some of the northern areas from when he came through that region, over 2,000 years ago. So there's a lot. I would highly recommend it. Another country that I'd recommend, if folks are not that adventurous yet, is Vietnam. That was the last country we visited right before. We typically go on a vacation, once a year near the end of the year. And Vietnam we did right before the beginning of the pandemic in November of 2019. And it was amazing. Like very, very, once again, it just reminded me there's things that I have to learn. There are impressions that I have that we shouldn't always be as confident in our knowledge of things as we are. So it was amazing. It was a truly a great experience. So those would be, I know you asked for one, but I gave you two.
That's okay. I'll take two. Yeah, that sounds, Pakistan and Vietnam sound like great opportunities. And I love that you talked about you didn't use the word kind of humbling, but we shouldn't think we know so much. So I'll flip it over and call it
I think
humbling.
it's
I found
absolutely
travel.
the right term. It really makes you realize, that there's always something new to learn and a new perspective and a new experience to have.
Mm-hmm. Great. Well, on that, we'll end this for now. And I just want to say thank you so much for coming and spending the time today with us and kind of talking through all these different topics and so much change and transition and such great opportunity within all
Absolutely.
of it.
No, it was spectacular. Do you mind if I leave with one thought, since there might be some aspiring startup people
Please.
out there, or people that are thinking about an experience? You shared your experience, your experience with healthcare. Just a little bit about our origin story. So my dad has got multiple chronic conditions, heart failure, and diabetes, and high blood pressure. And he's a very well educated, highly sophisticated person who's done like some really amazing things. But his challenge was around, his doctors were having trouble managing his complex medication regimen for a lot of the reasons that I've already shared, the complexity, the lack of coordination. And that's really one of the founding reasons, like, why we experience so much stress and uncertainty. And he experienced a lot of like poor outcomes and so on and so forth. And that's one of the driving reasons of why we launched Lumi Health and why I was so passionate about this problem. So the thing that I would leave everybody with is, if you've experienced something in healthcare, or somebody that you know, or a loved one, you could probably summarize that there are thousands, if not tens of thousands, or potentially millions of other people that are experiencing that same problem. And if you want to, build something in that space, after doing some research, you'll probably find that there's actually something buildable there. I mean, you just talked about, the lack of certain types of people to do x-rays and paper and digitizing that experience. There's so many parts where we need smart people to build things, and people that actually have experience and knowledge. You don't have to have the domain expertise. I mean, having just gone through something like that can be really insightful. So I would definitely encourage folks, if you've had those type of experiences, and I'm pretty sure many of your listeners can probably point to at least one or two things, then that might be a starting place to think about where improvements can be done.
That's a great. I love your origin story, that it's personal and genuine, and you're right, there are a lot of problems to solve. So I love the idea about asking people to find them and letting them know that there are opportunities for them to start their own.
Absolutely.
Found their own company to solve those problems.
Without a doubt.
They're fun. So thanks again so much for your time today. And that's it for the Message Engineer podcast. Please like, subscribe, all that good stuff if you enjoyed what you heard today. Thanks for joining us.